18, their number of ACEs is determined. That's it. Which is not to say that people can't have adverse adult experiences, because they do. But we're talking about things that have a long-lasting effect on adult health care. Also talking about witnessing domestic violence in the home, witnessing parental separation or divorce, death of a parent, incarceration of a parent, substance abuse, mental illness in a parent. So these are all things that I think are widely considered to be fairly traumatic for kids. And but prior to Felitti and Anda doing this work, hadn't been recognized as having adult consequences. And they found some pretty astonishing findings that they were able to take a number of adults of health and correlate them in a linear fashion, increased risks associated with increased ACEs. So many of these graphs for things like tobacco abuse, substance abuse, mental illness, unstable relationships, poorer educational achievement, earlier development of hypertension or cardiac disease, diabetes, lung disease,
cancer, head
cancer,
injuries, skull fractures.
Right. So, and some of those, things are directly related to, as you might call them, lifestyle choices such as drinking or smoking. But the correlations are linear on pretty much all of those factors that have been identified. So if you have 0 ACEs, 1, 2, 3, 4, and then you have the progression of risk for diabetes, the curve goes like that. It's not a curve, it's a straight line, and it's a direct correlation. So looking at numbers of ACEs is a pretty decent proxy for estimating someone's risk in adulthood of adverse health consequences. So what we started out doing with the first study, which was a co-op study several years ago, was trying to look at how acceptable it was to patients to have yet another survey. And in a population of adults presenting for follow-up of chronic health problems or for an annual physical, how difficult was it for the patient to fill out this 10 question survey, and how difficult was it for the clinician to incorporate that into their visit? They might or might not address the issues, and was this survey acceptable to patients and clinicians? We found that it was, and that the incidence of ACEs was very similar to other research, meaning that about 20% of patients had 4 or more ACEs, which puts them at pretty high risk of adverse consequences. It was acceptable to patients, it was acceptable to clinicians. It sometimes added a little more time, but usually no more than between 5 and 10 minutes, which I know is a huge chunk of our visit, but it also frequently added information that the clinician had not previously known. So it was intriguing that this was potentially feasible to incorporate into practice. So then, I guess cutting to the chase, what Ann and I were talking about this morning at breakfast is a vision that many, many research steps down the road, we would be able to identify effective interventions for people who have been traumatized and help them heal. And even more to the point, be able to go back and anticipate those adverse consequences as they happen. You know, when a kid's parents are getting divorced, what do we do? What would be a best practice to mitigate that damage? How could we keep them from being harmed in adulthood from that event? So that's, I think, the ultimate long-term goal as I see it. But as a next step, one of the things that what we thought might be useful, we didn't ask if people thought that these were issues or not. We thought with this next study, we'd be looking at, fill out the ACE questionnaire again, and then find out, is this thing still bothering you? And if it's bothering you, do you want help for it now? sometime. Not sure, or no, not gonna bother. And then we also wanted to look at resilience and on the backside and try to get some sense of people's self-assessment of coping mechanisms or coping ability. Whether that will correlate or not with the severity of their ACEs, it remains to be seen. But then again, perhaps if we start to get a handle on resilience and how one strengthens it, perhaps we start to make progress towards preventing some damage or mitigating some damage.
And then the stuff on the log is going to let you connect it to giving up those log cards. You want to talk about how the comments go.
Yeah, so the Codman card, I don't know if people are, this is sort of ancient co-op history. And there must have been a person named Codman who developed it, I don't remember who it was. This was in an era of paper charts and clinicians mostly being male and having a shirt pocket. And the idea was that it was the right size to fold and put in your shirt pocket. Like I said, ancient history. But it is a very convenient way to gather a lot of data in a small format with not much time spent recording the data. And that's the beauty of the Codman card. So that's your little form here. And if you keep your the date, the ID number of the survey, your patient medical record number, or your identifier that helps you find them again if you need to, not to go into the study data, but for your own records if you want to follow up with somebody. And then the type of office visit, whether they've got chronic illnesses, and specifically looking at a proxy for how much damage in terms of someone's health was inflicted by their ACEs. How many times do they come to your office in the course of a year? If you know how many emergency room visits, that's lovely too, but that's so diffuse. I mean, I have patients where they could go to any of 4 different ERs for a given problem or an urgent care center. So I have no good way of tracking that. So that's not accurate data. What is accurate is that I can search my EMR for how many visits they made to our practice over the last year.
But we have some sites that do have that ability to
Right.
have one system.
Well, it's hard to know, like I have patients who go to the ER somewhere else,
Mhm.
and I don't know that.
They might or might not send you a copy of that ER report.
And that we may not keep that data. We've been back and forth about this all the time. We
Right.
got it on there because that's what people wanted to do for big places that had a system.
I think there's data, I'm not sure where from, I thought, I heard someone say that there is data that just screening for ACEs can decrease ER visits over the subsequent 12
Yes.
months.
Yes, I think there was, I don't know if it was Felitti, I
I
think
think it was
Yes.
I think it was Felitti, and he had funding for implementing that. And for the year or two that they had that funding,
And it went back up again.
it dropped and then it went right back up. So that sort of indicates that just asking, which is sort of the mantra about previous things that were untouchable, like asking about alcohol, asking about drug use, asking about domestic violence, all of those kinds of things, it's been pretty well documented that if you ask, you get information and you get behavior change. Okay, so I think I'm done. Did you want to add some other stuff?
Just to add something, behavior change is really important, I think. What do you do with the data? What do you do with this information from the patient next? So part of it is starting to collect data, but the other part, what do we do with it? And so with ACEs, it creates mechanisms for what leads to chronic health issues. And a lot of them, and they're not just related to substances. So having anybody here work with kids, little kids, and they come in and they're all over the office. They're wild, and what's the first thought on diagnosis? ADHD, right? And a lot of times that's misdiagnosed as ADHD. Is they live in a chaotic environment and so, they go to school and they're put in the corner, or they're given some sort of interventions, and they're taught over and over again, and reinforces over and over again, perpetuates that they're not, they're not okay. And so they go to the doctor and they get prescribed a stimulant, usually, and it just kind of reinforces it over and over again. The behavior doesn't change. So I guess what I'm getting at is that the mechanisms, how do you enhance resilience? And part of that would be to offer some sort of mechanisms for them, adaptive behaviors that they can replace the maladaptive behaviors with. So part of this is obviously counseling, and it can be in the exam room or sending them to psychotherapy. But one of the challenges with sending off to psychotherapy is, one, you don't know what they do after you hand them off, and often you never see them again, or you never really hear from the clinician. And there's so much variability on how therapists work with these issues, and I think a really large variety of success. So I'd like to also explore that. What do we do with the information? Does anybody here have things they've seen that work really well with ACEs?
For 9 years, that the residency program at Eastern Maine, we collect this. It comes up like a allergy in the chart. I knew that I won about 5 years ago when in the precepting room and in rounds, morning rounds at the hospital, people were like, what is this person's ACE score? We need to understand that about them. And I always go back to Fletty about that the power of the intervention is just in the asking and then the engagement about it. And then I believe it doesn't you do different things for kids and adults, but and now the residents, when they leave, are pissed that there aren't these sorts of programs, and they take the intervention with them. So yeah, I think it's been incredibly successful at our institution, and the language of both what's the patient narrative and what's the patient's ACE score is just, everybody speaks that currency.
Mm-hmm. So that shows up
when the patient comes
in essence
in
on
and you
the front
open the
page
record,
of your
allergies pop up and their ACE score.
Fantastic.
Sort of like they're allergic to trauma, and if it gets triggered, like you get poison ivy.
Well, and it's the reminder isn't just that; it's that you need to have a conversation today. You ask these questions. Don't push this off to your MA. You ask these questions. Ask this time. You know this, and that this is part of the chronic disease that you're treating.
Right.
What I do is put it under past medical history, as whatever their ACE score is. And what I've found in terms of treatment is that it's not a fast thing. It's a slow thing. The patient may have come to me for 15 or 20 years before really feeling ready to go into much detail, although there's been sort of a dance around the bad experiences for a long time before there's any detail. And but it's been part of our phone conversations about this project. Is like with depression, if you're going to, they say if you're going to screen for depression, you have to offer treatment. You have to have something which you're ready to do if you find it, and so that you can actually help. And so in part, that's the relationship that you have. You offer the relationship as part of the treatment, as I see it, and then I'll offer them a book. But it's really not a fast, just go to this expert and they can, it's like the skiing program skiing, you can learn it, or they give you your money back. It's a gradual thing.
But one of the things that seems to me, in the past, I've felt like I was inadequate if I was listening to something and I didn't have something very specific to offer. But many times, patients are grateful simply to be heard.
Right.
And so, to some extent, just asking is an intervention.
Right. And
It's an acknowledgement of their life.
Which is part of the theory and practice of narrative medicine.
Right.
And the other thing is that these patients tend to be time suckers. They just eat up your clinical visit time, and if you have an expedient and tested means by which you can bring out something from the chaos, you've provided some personal satisfaction and also given the patient some kind of a handle on the situation, which otherwise can be going off in so many different directions.
I think the right side of the form is just such a huge leap in thinking about ACEs and screening for ACEs to not just historically what's your exposure, but currently what's your experience with us. And does it still bother you?
Yes.
The opportunity that you have to then correlate that with the medical record. Is the frequency of chronic conditions match exposure, or does it match current experience, or whatever? And it might mean with an ACE score, you don't have to talk about everything. You may be able to reflect on doing it and then focus on the ones that still bother. Or even say, of the ones that don't bother, wow, how did that? I mean, you're pioneers in asking that bother question, and it just.
I'm wondering if, we kept wanting to get out there at the point of practices, recruiting practices to start, but maybe one of the ways to get at this is ask the clinicians afterwards to either write down or talk to us about what they did in their visits. And we capture the narrative part of what happened when they were screened. I mean, what we want to get to a point is to help other people approach ACE, right, in their practice.
Didn't Maureen pilot this? Something similar to that.
I don't know, you mean asking people? Maureen was part of the earlier study where we did ACEs.
Right, and then she had to fill out her own survey about how she thought the visit went
Right.
after.
Right, we did a
Yes.
survey and looked at the length and
Yeah.
stuff, but it wasn't how did you respond to the patient in this visit? And it may be the way to get some of that naturally harvested without getting the clinician to do tons of every visit writing, which is what we don't wanna do and grind people to a halt.
No, I think it's a great idea, except I think you also have to train people to think about the things that they do that they don't actually value. For example, therapy types are trained to think of validation and support.
Mhm.
Doctor types are not trained to, they don't think that way. I didn't do anything today, they'll say. But like you ask these questions and you listen to their story and you said, we'll talk about this next time. And you're a doctor, that's huge. And so when they began to value that, now in precepting they say, today I just listened, and next time, I'm going to get back into some of this other stuff. And so that's how they think. But
Yeah, and that's not a just.
no, that is not a just.
Yeah.
Is there any thought about referrals to community resources?
Mhm.
So this
Yes,
is something
that's-
that's coming up in the community engagement work we're doing in Western Maine as part of the CTR. We're kind of developing this map for officially referring patients to community resources and kind of building, community resiliency.
Yeah, in particular, referral is one of the things that would come out of this, but we're kind of all being aware that there's a bunch of people that may not be ready for a referral, is what I'm hearing.
And I would say regarding robust medical intervention, this siloing of mental health we should get away from community mental health. All mental health should be delivered in primary care, in my humble view. Not that I'm a complete zealot, but.
Well, and that's one of the things that Dan's.
I agree. I mean, I think we're co-located, and that is really great. And we can't. I'm only one person, so I can't see everybody. But that's how it starts.
And I would also add that part of the problem of managing ACEs is that the last thing you want to do, if you send people away, oftentimes people are psychiatrically trained and they still think about the DSM, which is highly problematic because if you take a trauma history and make it a psychiatric issue, that is like anathema to health, in my humble opinion. And when you get specialty psychiatric care, then you have specialty psychiatric prescribing, and then suddenly you're down a whole other path that you wouldn't even be if you focused on just the narrative and the health issues. And
I think when you see the symptoms, they look at it in symptomology. When you look at the symptoms, you can take your eye off the ball. Focus on the ACEs and start there.
And focus on health.
And focus on health. And so one of the questions I ask when somebody says that an ACE still bothers them is, how does that show up for you today? In a very broad way, how does that show up for you today? I get all sorts of really great information from them on, I can't trust in relationships. So, and the person has like maybe 2 or 3 kids with several fathers, and some sort of disease that comes out of that, or binge eating, or whatever. The list goes on, and so developing an understanding of how the ACE or the ACEs are impacting them now, that you can target right away what to do with that, as opposed to like looking at the symptoms and you're missing the point.
We have a huge narrative study going on right now, and we find, like, I knew that we won this one in the last year and a half when a resident said, next time I'm going to actually just treat the story. And by treating the story, it was installing a different narrative with the patient, developing a different narrative with the patient about about their identity. I mean, this stuff gets at identity. Right. And anything that moves people towards psychiatry is a problem, fundamentally. I mean, for lots of reasons.
So I have a question to the group. Do you want for this next study to give docs a cue sheet about how to respond to ACEs?
Yes.
So, yes, and I think, like, as a primary care, looking at this, when I'm going to give somebody this form, and I'm going to get it back to me, and it says, I would like help today, and how many visits are checked? What's my menu? You know what I mean? Because I think that's the stopping point for, like, I would say of the clinicians in my office, I'm probably the most, interested in this, but even for other clinicians that I work with who are interested in mental health and interested in ACEs, that's the sticking point. It's that helpless feeling.
And
so seeing that menu of listening to the story being one of the things that you did, offer reference to these books, one thing that you did. You know what I mean? Like those.
If you give me your email, I will email you this. I have a cheap pocket card.
Yeah.
That
I think it would be so helpful.
When we've sent it out on this list a couple of times.
Except people who are experienced clinicians had trouble resonating with what you did for learners, is what I remembered. So I think we have to create our own thing out of all of that. Mm-hmm. That people say, here's a cue. Here are some ideas when you have people with positive ACEs.
Yeah, but from the clinician standpoint of carrying it out, but also from the data, I'm like, that's what's missing. You know what I mean? Like, how can you collect this? And then like they said, yes. What did you do?
Yep.
You
presented a nice model a couple of years ago about 3 stages of severity that they did in obesity counseling.
I was just going to mention that, and actually I've got a poster that you can see that when the poster time comes. But the idea was to stratify maybe 4 levels of need, and then match that with 4 levels of intervention, which might be just listening, or it might be referring to some resources, it might be developmental guidance, all things that you would do. There might be a level where it needs specialty mental health beyond primary care, but not everybody needs that, and maybe the minority.
Well, the majority, this isn't the reason why they're getting that referral. That's from other things that we knew about already.
Mm-hmm. So we could be so elaborate as to do 4 levels. We could also do suggestions in a couple tiers and not make people have to find the box they put in. But what I hear is, in order to be comfortable doing this screening, it will help people to be cued, right?
So as to a resource.
Things to do.
Like you have a book you like, people have, and we can give people a card if they want the full card, but that they get some materials about what to do.
Right. So what I think maybe we all want, or I'm speaking for myself maybe, is I want these resources. I want you guys to share.
Send them in.
What you're doing and what you developed. And so we need to have a contact, I guess, location for sending that.
You can send it to Troy and just label it ACE stuff, and she'll get it back
On email.
Mm-hmm.
Okay.
The 2 things that came out of our
So
community.
then we need Troy's email.
It's all over our materials, but I'll get it specifically from people. Okay.
Community engaged research meeting where, in terms of interventions, where access to resiliency building, and there's certainly tools around that, but having access. And I think community support, I agree, embedded mental health and primary care is critical, but having community resources can augment, because they're only with us a short amount of time. And then access to trauma-informed care with therapy, so having, because there's specific skills around trauma-informed therapy, and so having access to that specific type of intervention.
So what a practice would wanna do is find out where that is in their community when they're beginning. Isn't it, they're stuck. I keep hearing that you're coming up with a end survey of some kind from the docs who've been doing this. You wanna hear back after people have screened 20 or 30 patients, what they've been doing, don't you? So that you have to create something that they say, I like I said, not at every encounter, but at the end, what have they been doing? The other practical part is we need 20 minimum, 30 preferable providers to get enough power to do, if everybody did 20 to 30, to look at things. And that's when we got hung up after our last phone call. We had some people on the phone and not other ones. So one of the tasks today is either here or people that you work with, how do we get that number? And then in this world of IRBs, for main sites, we have to have a reliance agreement with whatever IRB you have. So we need to know that part as well. Who do we go to? Like, we know we've got to go to UVM for UDAN, right? Because we've been through that once.
We have our IRB, and we have several agreements with you guys already.
Yeah, so you should be able to just send the protocol.
How many sites, can you clarify how many
I was
additional
counting
sites?
docs, not sites, because you may have a site that a couple of the docs would want to, docs are with practitioners, this is not a doc site. So we're trying to get 30 clinicians.
And you're at 0 at this point, or?
Yeah, well, we have the interested people who are here, the list is going around for people that, stick your hand up if you're interested in doing it.
I can go over 10.
All right,
So,
Squeeze those people in lines.
all right.
so we just need a
And I
better.
can probably muster half a dozen clinicians at my site.
What we're trying to say, this is time limited, they're not having to do it forever.
Right.
We've got research coordinators from our sites, and are you connected to practices in your networks that we could reach out to?
The other cool thing about ACEs is it's a one-time determination. And it can go into the medical record as such. People's smoking habits or drinking habits change all the time. Their numbers of kids can change. Even their level of education can change. But ACEs, they end at age 18, so it's a one-time questionnaire and it can be put into their vital statistics.
Except, again, the opportunity here, this could be a later study, is whether it bothers them might change.
Yes,
And that
right,
might be
yes.
interesting.
I'm just saying that as far as information gathering, it's not something that has to be done every visit. And once it's recorded, it's there. What you do with it, of course, you're right, is different over time.
I like the idea of making sure you give the clinicians resources of what do I do with this information, especially if they say they want help today or they become really upset while we're talking about it.
Mhm.
And so I think that's essential. I think you'll get more participation from clinicians if you give them some things that they can, some tangible, concrete things that they can do in the room.
One of the things that's really amazing is how much work across the country is going on with these. In South Carolina, they have all these different trauma network efforts going on, so it's really limitless.
But it may not be you have a trauma-focused therapist.
Right,
in your community.
trauma-informed care is evolving.
And if you don't harvest, that's the thing. If you don't have clinicians in your community, can you find a way to either train the people who are willing to get the training they need, or recruit the people that already have the training or are willing to get the training they need? So the recruit, I think that's important, and I think that's really hard in rural areas. Hard to recruit in Vermont. Yeah, Vermont, New Hampshire, I'm sure it's pretty challenging there too.
So how does a clinician find out if they have trauma-informed care resources in a community?
You hear all about it every meeting you go to.
Yeah,
Yeah,
I think, plus, I mean, everything is like safe church, scout leaders now all have to have chaperones for the leaders. I mean, most organizations now are sort of trauma informed in their structure. I mean, it's
right, but it's not about helping an adult who needs trauma-informed care, right? I'm aware of.
sometimes it is,
Okay.
Yes.
or a grown adult, young adult.
Our behavioral health people are trauma-informed specialists.
Yeah.
Within Little Rivers, we have a couple that have joined the team, and so now they're tapping into the schools, but they're also addressing the adults that are coming into the practice.
When you're doing trauma-informed care, you're not just jumping right into the disturbing material that they've experienced.
Right.
Obviously the ACEs does touch on that, but usually it's something where they can answer the questionnaire and pretty much be okay with it. But you're building resources first, regardless of whether you're in a therapy office or not. And so that's where I think we might, if you ask your patients, what kind of coping skills do you have? A lot of times they read this, like, what do you mean? And they don't know how to answer that. But
That's how they're dealing with it.
well, yeah. Or they don't have the skills. So that's something, tomorrow morning I'm gonna be talking about skill building. You can do really brief skills you can teach your patients in the exam rooms. 5 minutes or less. We're not sitting there meditating with them for a half an hour, because nobody has that kind of time. But that's sometimes where it starts. It's just building the skills. And if they have the skills, then, you also want to know more about that resilience. That's why I'm so glad that you guys, included that in the study. Because where does the resilience come from? And you can build upon that. So that's one of the next steps. And then you go from there, and at some point, then you start to delve into the traumatic material that they've experienced. But, it isn't necessarily just call Joe down the road and he'll get you in for therapy. There can be some work that happens in the primary care office, even if that's my vision. I mean, I love the idea of having co-location of all behavioral health is co-located in the primary care office. But when you can't, finding ways to bridge that a little easier for the patients is really important. So my thoughts are, I really like the resourcing idea, just as far as books. And not everybody's going to read. That's really important. Like I have a very small amount of people who, give me a book. But skill building and referral sources and support groups and there's layers of all sorts of different resources. So being able to develop something that's preferably evidence-based too.